Hello, nurses! Can you believe we're done our first week of Nursing 500? I'm going to talk to you all today about our first middle range theory. The theory I chose to talk to you about is called the theory of self-care of chronic illness. It was developed in 2012 by 3 researchers named Barbara Riegel, Tiny Jarsma, and Anna Stromberg. Before we get too far in the theory, let's go back and find out where it came from and why. First of all, what exactly is a middle range theory? Middle range theories are theories which describe a view that deals with a specific phenomena and commonly come from nurses' clinical experiences and are usually influenced from ground theories. The theory of self-care of chronic illness was influenced by Dorothea Orum's grand theory of self-care. However, because it's a middle range theory, it's focused specifically on chronic illness. The goal of the theory was to categorize behaviors and activities used by people with chronic illness. The authors defined self-care as a process of maintaining health-promoting practices and managing illness. The theory evolved from experience caring for patients with heart failure. Challenges were seen around patients caring for themselves now that choices they made in their daily life needed to be consistent with the needs of their chronic condition. The authors wanted to evolve this work so that it would fit to a broader audience and be applied to different patients diagnosed with different chronic illnesses. The theory of self-care of chronic illness acknowledges that most patients seek care because they're looking for relief from symptoms. This theory requires that providers partner with patients and work to motivate patients to be involved in self-care activities that can be done as part of their daily living, making them active participants in their own care. During this partnership is when Riegel, Jarsma, and Stromberg say self-care of chronic illness takes place. The theory operates on 3 assumptions. First, there are differences between self-care of chronic illness and day-to-day self-care. Secondly, decision-making requires a certain cognitive level. And lastly, self-care is complex when patients have multiple comorbidities. Okay, let's move on. There are 3 main concepts to the theory. The diagram is laid out in a specific way that connects self-care maintenance and self-care management with the concept of self-care monitoring. Patients can move in and out of different areas of the model. Self-care maintenance, self-care monitoring, and self-care management. Self-care maintenance is defined as behaviors performed to improve well-being, preserve health, or to maintain physical and emotional well-being. Self-care maintenance can be performing tasks recommended by the healthcare providers, family, or even things the patient thinks they should be doing. For example, preparing healthy meals and taking medications as prescribed. Self-care monitoring is the process of routine, vigilant body monitoring, surveillance, or body listening. There are 3 criteria for effective self-monitoring. First, clinically significant changes are possible over time. Secondly, a reliable method of testing is required. And lastly, there must be a reasonable action and response. The goal of this concept is to be able to recognize that a change has occurred. For example, performing regular AccuChecks for a diabetic, or monitoring blood pressure for someone with hypertension. Lastly, we have self-care management. Self-care management involves an evaluation of changes in physical and emotional signs and symptoms to determine if action is needed. When a person becomes skilled in self-care management, they can carefully think of a potential action plan. The action will be specific to the chronic disease. For example, if someone with asthma has shortness of breath, they may take a bronchodilator. If another person with heart failure has shortness of breath, they may require an increase in Lasix. This phase may require the patient to work with their healthcare provider to come up with a plan and be able to evaluate effectiveness. The theory is created from a patient-centered approach to practice. The intended outcome of self-care is control and stability of illness, as well as improved health and well-being. Now that we've gone over the core concepts of the theory, I want to talk about the facilitators and barriers that can affect self-care. Experience and skill. Being familiar with a situation and having experience can help patients with self-care because they may be able to recognize the situation and act critically about how they want to act. On the other hand, not having experience may add to feelings of self-doubt. Skill is a critical aspect of self-care and one which patients may develop over a period of time. It's important for healthcare providers to assess experience and skills prior to making a plan of care. Motivation. A patient's level of motivation can directly impact their self-care engagement. As nurses, we also need to determine whether the motivation is intrinsic or extrinsic. Are they only motivated because of their spouse? Cultural beliefs and values. At times, self-care advice from providers may contradict a patient's beliefs and values. Confidence. Confidence is important for the patient to have in order to carry out self-care practices even in the presence of barriers. Habits. Some patients may find it easy to adopt new self-care practices as part of their routine, while a barrier may be the need to break a daily routine to enhance self-care in relation to their chronic illness. Functional and cognitive abilities. These may be physical requirements needed to carry out self-care activities. For example, do they have the manual dexterity to administer sub-Q insulin? Additionally, cognitive deficits have been shown to make self-care practices more difficult. Support from others. Many people will have support from family and friends, which may help them with their self-care activities. On the other hand, some may not and may require more help from providers. And lastly, number 8, access to care. Lack of access to trained healthcare providers is associated with decreased self-care outcomes. Okay, is everyone still with me? So far we can see that the theory of self-care of chronic illness combines the meta-paradigms of nursing by looking at the nurse's role in relation to the patient's health and how aspects of their environment will either support or hinder self-care. Great. Let's keep going. Now, what are we really interested in? Does it work? I went scouring the internet to find studies that have used the theory, and it was less promising than I had hoped. The theory is relatively new, but I found an abstract from a conference where the authors of the theory were going to present work they had done that used the theory to create a 20-item instrument measuring self-care maintenance, monitoring, and management of chronic illness called the Self-Care of Chronic Illness Inventory, or SCCII. The purpose of the study was to assess content validity for the instrument. 5 clinical nursing experts rated the items using the Content Validity Index. These results were quantified using a 4-point Likert scale, 1 being not relevant and 4 being relevant. In order for an item to be considered valid, it needed to be scored at a minimum of 3 by at least 4 of the experts, or a 0.8 overall. The initial stages of testing looked promising. After 2 rounds of testing, each item ranged from 0.8 to 1.0, with an average Content Validity Index score of 0.91. It consists of 8 self-care maintenance items, 5 self-care monitoring items, and 7 self-care management items. The self-care management scale is only to be completed by patients experiencing symptoms. Will this theory be able to help nursing knowledge? I believe it will. It's intended to be used by healthcare providers, not just nurses, but any member of the patient's healthcare team, to assess patients' self-care abilities. It's also intended to be used by researchers. Proper assessment of the patient's current self-care practices could help clinicians to develop appropriate and patient-specific interventions in hopes of increasing patient outcomes. Depending on which concept area the patient is struggling with, education and assistance from the healthcare team can be tailored to their specific needs. Is the patient unable to properly monitor their blood pressure, but takes their prescribed medications as ordered? They would need more education about self-care monitoring and not necessarily self-care maintenance. Researchers would be able to use this theory to study self-care in relation to specific chronic illnesses, as well as studies around different cultural groups' responses to self-care of chronic illness. Now, more about what I think. I like that the authors included facilitators and barriers to self-care management because I think it allows the theory to include all aspects of the nursing meta paradigm by adding more about the environment the patient is in and who is in the environment with them. This theory is parsimonious, accessible, important, and usable. In today's healthcare world, we need to encourage and help patients to be able to monitor chronic illness effectively from home. My only reluctance with using the theory is that it has not been extensively tested or used due to being developed in only 2012.